MACRA is the acronym for the Medicare Access and Chip Reauthorization Act of 2015, otherwise known as the Doc Fix Bill. This bipartisan legislation replaced the flawed SGR, or Sustainable Growth Rate, which, had it gone into effect, would have significantly reduced Medicare provider payments. The SGR is thankfully gone, and beginning in 2017 is now replaced with this much more predictable program called MACRA. MACRA will increase the number of physicians who are participating in something called Alternative Payment Models, or APMs, which will be discussed in more detail later. With those in high quality, efficient practices receiving significant financial benefits. There are many legislative changes included in MACRA, and as the name would suggest, it extends the funding for the Children's Health Insurance Program for an additional 2 years. The main thing it brings to us, and what we'll discuss today, is the Quality Payment Program. Now I'd like to introduce Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst.
The Quality Payment Program, or QPP, is part of a broader push towards paying for value and quality. For Medicare Part B, it's no longer a sheer numbers game where the more claims providers submit, the more revenue that's generated. Controlling costs and increasing the quality of care delivered are now important factors that must be addressed simply to maintain current Medicare reimbursement levels. There were some embedded goals attached to the initial years of this program, which in 2019 is now in its third year. The first goal was to have 30% of all Medicare payments tied to quality or value through alternative payment models by the end of 2016 and 50% by the end of 2018. Goal 2 was to have 85% of Medicare fee-for-service payments tied to quality or value by the end of 2016 and 90% by the end of 2018. CMS reported that they were able to reach and even exceed these goals well ahead of schedule. For now, this program only affects Medicare Part B claims, but over time, we should see the private sector launch similar programs to the Quality Payment Program. There are several strategic goals for the QPP: improve beneficiary outcomes, enhance the clinician experience, increase the adoption of advanced alternative payment models, maximize participation, improve data information sharing, and ensure the operational excellence in program implementation. For additional information on the Quality Payment Program, please visit qpp.cms.gov, a great comprehensive site for QPP program information and helpful tools. This conceptual diagram of MACRA can assist in your understanding of this complex program and the components of it being discussed today. At the very top, we have MACRA, the overarching legislation. There are many regulatory changes contained within MACRA, but today we are only discussing a small portion of them. A main component of MACRA is the QPP, or Quality Payment Program. Within the QPP, there are two paths of participation. One is MIPS, or the Merit-Based Incentive Payment System, and the other is APMs, or Alternative Payment Models. There are two types of APMs that are most relevant to the Quality Payment Program: Advanced APMs and Non-Advanced APMs, otherwise referred to as MIPS APMs in the program. The long-term goal of the QPP is to get as many providers as possible participating in the Advanced APM track. Initially, the majority of participants will participate in Path 1, the MIPS path, and over time, we will see the number of MIPS participants shrink as they make the transition to participate in Track 2 of the QPP, Alternative Payment Models. Let's begin by providing a brief overview of Path 1, MIPS, the Merit-Based Incentive Payment System. MIPS combines multiple legacy Medicare Part B programs, which you may already be familiar with, into a single program. It takes the Medicare EHR Incentive Program, otherwise known as Medicare Meaningful Use, the Physician Quality Reporting System, or PQRS, the Value-Based Payment Modifier, or VM, adds a fourth new category called Improvement Activities, and combines them into this consolidated program called MIPS. In MIPS, Meaningful use has undergone a name change and is now referred to as the Promoting Interoperability Performance Category, or PI. In previous years of the program, this category was called Advancing Care Information, or ACI, but CMS renamed the category in 2018 to better reflect its goal of increasing the electronic sharing of clinical data. Also, please note that MIPS does not end or affect the Medicaid Meaningful Use Program, which has also undergone a similar name change. That separate program, now called the Medicaid Promoting Interoperability Program, is scheduled to continue into Stage 3 in 2019 and continue through the year 2021. Participating in the Medicaid Promoting Interoperability Program and MIPS concurrently requires separate attestations. PQRS is now referred to as the Quality Performance category of MIPS, and the Value-Based Payment Modifier is now the Cost Performance category. In the first 2 years of the program, performance years 2017 and 2018, there were only 5 provider types that were eligible to participate: physicians, physician assistants, nurse practitioners, certified nurse specialists, and certified registered nurse anesthetists. In 2019, this list has expanded to now also include clinical psychologists, physical therapists, occupational therapists, speech-language pathologists, audiologists, registered dietitians, and nutrition professionals. Future years of the program may expand this list to eligible provider types, which will be determined through additional rulemaking. Please note that the term eligible professional, or EP, which has been previously used to reference participants in the legacy Medicare programs, has been replaced in the Quality Payment Program with the term eligible clinician, or EC. Taking a look at other facets of program eligibility, clinicians must participate in MIPS if they exceed the low volume threshold for participation, which in 2019 means that they bill more than $90,000 a year in allowed charges for covered professional services under the Medicare Physician Fee Schedule, and furnish covered professional services to more than 200 Medicare beneficiaries a year, and provide more than 200 covered professional services under the Physician Fee Schedule. CMS equates a covered professional service to one professional claim line. If clinicians do not exceed all 3 of these criteria for the 2019 performance year, they are excluded from MIPS. However, clinicians now have the opportunity to opt into MIPS if they meet or exceed 1 or 2, but not all 3 of the low volume threshold criteria. Clinicians are also excluded from MIPS in the 2019 performance year if they enrolled in Medicare for the first time in 2018, or they participate in an advanced APM and are determined to be qualifying APM participants, or QPs, or they participate in an advanced APM and are determined to be partial QPs and do not elect to participate in MIPS. There are different ways that clinicians can participate in the program, as an individual or as a group of clinicians. If participating as an individual, a clinician is assessed separately under each NPI and tax identification number combination. If the clinician works under more than one tax ID number, program performance is calculated separately within each TIN, and Medicare reimbursements are adjusted relative to that clinician's program performance at that location. In the group participation option, 2 or more clinicians who have reassigned their billing rights to a single tax identification number are assessed as a group of participants. Members are assessed as a group across all 4 of the MIPS performance categories. Program performance is consolidated, and all group members receive the same MIPS final score and subsequent reimbursement rate. Please note, if choosing to report as a TIN group, all clinicians practicing under that TIN must report as part of that group if they have data, even if they are not one of the eligible provider types previously discussed. While a group choosing this reporting option may be including data from non-eligible provider types in their submission to CMS, only the MIPS-eligible clinicians in the group will receive the program's financial benefits. MIPS-eligible clinicians can also take advantage of a program rule which allows for reporting data as an individual and as part of a group under the same TIN. In this instance, the clinician will be evaluated across all 4 MIPS performance categories on their individual performance and on the group's performance, with a final score calculated for each evaluation. In this scenario, the clinician will receive a payment adjustment on the higher of the two scores. Groups can also participate as an alternative payment model or APM entity. For example, as members of an accountable care organization or ACO. MIPS-eligible clinicians who participate in an ACO are locked into program participation at the group APM level and do not have the option of participating as an individual or as a TIN group. For those participants, the group is made up of the entire list of ACO participants, with each member receiving the same score and Medicare reimbursement rate. Lastly, clinicians can participate in the program through something called a virtual group. In virtual group participation, any number of solo practitioners and groups of 10 or fewer clinicians come together virtually, no matter what specialty or location, to participate in MIPS together. If you're familiar with how an ACO works, you may find it easiest to consider a virtual group as a mini ACO, as this option works much the same way as an ACO does by consolidating the data across more than one organization. To be eligible to join or form a virtual group, you must be a solo practitioner who exceeds the low volume threshold individually and is not a newly credentialed Medicare clinician, a qualified APM participant, or a partially qualifying APM participant choosing not to participate in MIPS. Groups that have 10 or fewer eligible clinicians that exceed the low volume threshold at the group level can also form or join a virtual group. Solo practitioners and small groups who want to form a virtual group must go through an election process with CMS. Virtual group election must occur prior to the beginning of the performance period and cannot be changed once the performance period starts. This election period was October 1st to December 31st, 2018 for the 2019 MIPS performance period. Whether participating as an individual, TIN group, or virtual group, the low volume threshold remains the same. In terms of TIN group participation, the dollar value of claims, the number of patients seen, and the number of billed covered professional services is consolidated across all group members. Thus, the group as a whole must have more than $90,000 in Medicare Part B allowable charges, provide care to more than 200 Medicare patients, and bill more than 200 Medicare covered professional services in the 12-month measurement period. Although group participation is optional, it can be used to allow individual ECs who do not meet the low volume threshold on their own to band together to meet eligibility requirements and participate in MIPS, potentially increasing Medicare reimbursement rates. Each of the 4 MIPS performance categories has an assigned minimum reporting period length, which can vary between categories and can also change from year to year. As was also the case last year, in 2019, the quality and cost reporting periods are each a full calendar year of 365 days. And the improvement activities and promoting interoperability performance categories must again be reported for a minimum of 90 continuous days in 2019. Thus, to maximize promoting interoperability category points, ECs or groups should choose a PI reporting period anywhere from 90 days to 365 days, using a date range that is most advantageous, earning the clinician or group the maximum points possible. Overall MIPS program performance is rated through the MIPS final score, a single composite score that factors weighted performance in the 4 MIPS performance categories on a 100-point scale. This final score is then compared to the overall performance threshold, which is established annually. In the first several years of the program, deemed transition years, CMS will determine the performance threshold which must be met to avoid a Medicare payment penalty. In future years, the performance threshold will be established based on the mean or median of the prior year's final scores. Those who score below the minimum threshold will see negative adjustments to their Medicare reimbursement rates. Those who score above it will see positive reimbursement rate adjustments. Any clinicians who score in the bottom 25% of total MIPS participants will receive the maximum penalty for that program year, which is 7% in 2019 and increases to 9% in 2020 and beyond. Performance category weights may be adjusted if there are not sufficient measures and activities applicable for each type of clinician, including assigning a scoring weight of 0 for a performance category. Reweighting of the performance categories is automatic for some participants, such as hospital-based providers, with an application process available for other conditions, such as extreme or uncontrollable circumstances. As was just mentioned, the MIPS final score is derived from performance in the 4 performance categories, which are individually weighted on a 100-point scale. These performance category weights were designed to shift through the initial transition years. In 2017, quality was worth 60%, advancing care information was worth 25%, improvement activities was worth 15% of the MIPS final score, and the cost performance category was weighted at 0. As expected, these performance category weights have changed each year, and for 2019, quality is worth 45%, cost is worth 15%, improvement activities is worth 15%, and the newly named Promoting Interoperability performance category is worth 25% of the MIPS final score. Once we're through the transition years, the final category weights will be quality at 30%, cost at 30%, promoting interoperability at 25%, and improvement activities at 15%. There are several options available for submitting MIPS data to CMS, and participants need to take the time to plan for and implement which submission options will be used. Options vary based on individual or group reporting, can vary between performance categories, and in the case of quality data reporting, can even vary between reported quality measures, which is a new option in 2019. In previous program years, quality data could only be reported via one submission method. Now you have the option to submit each quality measure via a different method, which can significantly impact the EC's category score, as quality measure benchmarks, against which performance is rated, have been established separately for each data submission option. With this variation in benchmarks relative to the reporting method, what is a high quality measure score using one submission method may translate to a much lower quality measure score utilizing a different submission option. Quality measure benchmark information, broken down by data submission method, can be viewed and downloaded at qpp.cms.gov. If applicable based on performance, adjustments to a clinician's or group's Medicare Part B reimbursement rate is applied 2 years after the performance year, as was the case in the former legacy programs, Meaningful Use and PQRS. So the 2019 performance year affects the 2021 payment year. MIPS, for the most part, has been designed to be budget neutral, so ECs receiving negative rate adjustments pay for those receiving positive rate adjustments. Unlike in the previous legacy programs, the adjustments are linear based on the final score as compared to set minimum performance threshold. Payment adjustments tied to the 2019 performance year will range anywhere between -7% and +7%. As previously mentioned, those scoring in the bottom 25% of total participants will automatically be adjusted down to the maximum penalty for that program year. Higher scores receive proportionally larger rate increases, up to 3 times the maximum positive adjustment for that year. This 3 times modifier will be used to maintain budget neutrality. The top performers will also be eligible for something called the Exceptional Performance Bonus, an additional pool of $500 million a year to be awarded to top program performers. Clinicians in the top 25% of total participants may receive up to an additional 10% increase in reimbursement rates as a reward for outstanding performance. This means that in future years of the program, ECs have the potential to receive as much as a 37% increase in Medicare reimbursement rates. In summary, the MIPS minimum performance threshold is established each year and in future years will be the average of final scores received in the prior performance year. Those scoring below the threshold will receive a negative payment adjustment on Medicare Part B rates, with those in the bottom quartile automatically assessed the maximum penalty for that year. Those scoring above the performance threshold will receive proportionally higher Medicare rate increases up to 3 times the maximum adjustment for that year, with those in the top quartile of performers receiving up to an additional 10% rate increase for exceptional performance. We'll now discuss the other participation path of the Quality Payment Program, alternative payment models. Alternative Payment Model, or APM, is a generic term describing a payment model in which providers take responsibility for cost and quality performance and receive payments to support the services and activities designed to achieve high value. According to MACRA, APMs in general include Medicare Shared Savings Program ACOs, demonstrations under the Healthcare Quality Demonstration Program, CMS Innovation Center models such as the Qualified Medical Home, and additional demonstrations required by federal law. The Quality Payment Program does not change how any particular APM pays for medical care and rewards value. Instead, the QPP enhances that payment methodology by adding additional incentives for clinicians. And if applicable, APM participants who are still participating in the MIPS track may receive favorable scoring under certain MIPS performance categories. The long-term goal of the Quality Payment Program is to significantly increase participation in the highest level of APMs, those meeting the criteria to be defined as advanced APMs. Within the QPP, there are 3 types of alternative payment models. At the top, we have advanced APMs, a term established by CMS which denotes those APMs which have the greatest financial risks for providers and also offer the greatest potential for rewards. 3 criteria need to be met for an APM to be deemed an advanced APM. First, 75% or more of the APM's participants must use certified EHR technology, otherwise known as CERT. The entity must report and at least partially base clinician payments on quality measures which are comparable to those available to participants of MIPS. Finally, and perhaps most importantly, to be an advanced APM, participants must bear more than nominal risk for monetary losses for poor performance. This level of risk is defined as the lesser of 8% of total Medicare revenues or 3% of total Medicare expenditures. Current examples of advanced APMs include, but are not limited to, Medicare Shared Savings Program ACOs, Tracks 1+, 2, and 3, Next Generation ACOs, the Comprehensive ESRD Care Model, and the Oncology Care Model Track 2. A complete listing of available advanced APMs can be found at qpp.cms.gov. Advanced APM benefits include shared savings, flexible payment bundles, and other desirable features, none of which are altered by the Quality Payment Program. As previously mentioned, the QPP adds additional financial incentives on top of the current APM payment model. In 2019 through 2024, ECs significantly participating in advanced APMs will receive a lump sum bonus equal to 5% of their Medicare Part B reimbursements for the measurement year. Additionally, starting in 2026, annual baseline Medicare payment updates will be higher for advanced APM participants than for MIPS participants. Finally, since advanced APMs include their own requirements for EHR use and quality reporting, advanced APM participants are exempt from participating in the MIPS track of the Quality Payment Program. Next, we have qualified medical homes, which are certified medical home models which have been expanded under CMS authority. They have different risk structures than the previous category, but are otherwise treated as advanced APMs. To date, the Comprehensive Primary Care Plus, or CPC Plus program, is the only medical home model available which qualifies as an advanced APM. Finally, we have MIPS APMs, which make up the vast majority of current APMs available, including the Medicare Shared Savings Program Track 1 ACOs. To qualify as a MIPS APM, the entity must participate in a model under an agreement with CMS. It must include at least one MIPS-eligible clinician on a participant list. And finally, the APM's payment model must be based on performance against cost and quality measures. The advanced APM benefits do not apply to MIPS APMs. Their members must participate in MIPS to receive any favorable payment adjustments. They do not qualify for the 5% lump sum bonus and are not eligible for the higher baseline annual updates beginning in 2026. There are, however, still significant program benefits for participating in a MIPS APM. In 2019, most MIPS APM participants automatically receive full credit in the Improvement Activities category of MIPS. They still receive the shared savings rewards built into the APM's payment model, and these clinicians are eligible for MIPS rate increases, which continue indefinitely versus the limited 6 years planned for the 5% advanced APM lump sum bonuses. Taking a look at the Quality Payment Program timeline, we see that the Medicare Physician Fee Schedule will still see modest rate increases through 2019. Between the years 2020 and 2025, the only way to receive increased financial benefits will be to participate in one of the two paths of the Quality Payment Program. In 2026, the Medicare Fee Schedule will once again see annual positive adjustments, with the rate of increase dependent on whether or not the clinician is significantly participating in advanced APM. In the MIPS track, reimbursement rates will be adjusted within the range of plus or minus 7% in 2021 and increases to 9% in 2022 and beyond. Those clinicians significantly participating in an advanced APM will receive lump sum incentive payments equal to 5% of their Medicare reimbursements and are exempt from participating in MIPS. In summary, we are in the beginning stages of long overdue Medicare program payment reform. As was the case with the legacy programs it replaces, we will continue to see the QPP evolve over time. The long-term goal of the program is to push eligible clinicians into advanced APMs. Potential MIPS incentives are significant for high performers and could reach as high as 37% as the program matures. There is also the risk of significant financial penalties for poor performance. As the program develops, there is the potential for a 46% gap in Medicare reimbursement rates between the highest and the lowest performers. Also, each participant's MIPS scores will be publicly available on the CMS Physician Compare website, allowing patients to shop for providers demonstrating high quality and value.